Hey everybody, welcome to another VITA Academy webinar. Today we are going to have Mr. Peter Peasy talk about shade and photography that will basically be the essentials of any treatment planning, especially those of you that actually don't see the patient firsthand, which would be ideal. But there is some sort of communication that has to go on that you have to actually be able to see what the case is you're working on. So welcome, Peter. How are you doing today?
Good, Jim. How you doing?
Good, good. Peter is a worldwide dental educator for technicians, dentists, auxiliaries, owner-manager of Peasy Dental Studio in Staten Island, New York. Has a personal appreciation, expertise in all phases of clinical, laboratory, traditional, digital techniques. He does it all. Color communication, digital photography, etc. He's a board member of the Association of Master Dental Technicians, teacher and educator in the Master Dental Technician program at New York University, faculty member at NYU School of Dentistry, member of the American Academy of Aesthetic Dentistry, executive board member and fellow at the Northeastern Pathological Society, editor-in-chief, Inside Dental Technology, and was the ACP Technician of the Year in 2018. So I am going to go ahead and turn it over to you, Peter. Let me make you the presenter.
Well, thank you, Jim. I appreciate it. And as always, an interesting topic and title to put together here. So, excuse me, Jim's title that he kind of built, and I give him the credit for it because he kind of throws the titles out there based on the information that you guys give him. And this one was Shade Photographies and Treatment Planning. So putting them all together is kind of an interesting, complex scenario because there's a lot that goes into it. So first, let's start that I think the minute we hear the word photography, it really becomes about one thing in most people's minds, and that's shade taking. And I would make the argument that shade taking is a huge part of photography, but at the same time, it's a small part compared to all the other uses that it has. So for me, I'm using photographic communication, and I like to kind of think of it that way rather than just photographs. I'm using the communication tool really for my treatment planning, for my shade taking, for my consulting, for maybe even material selections and aesthetic parameters, and sometimes even the functionalities, right? Being able to see the jaw move or on a video, or looking at wear patterns that you may not have gotten in the impression based on the quadrant model compared to a full arch. So I think when I'm looking at treatment planning, the things that come to mind probably right away for everybody is aesthetics, function, and then for us in the laboratory, material options. Which ones do we want to use and where do we want to use them? But I also think there's more to it, right? Because first off, if you're working on a simple single unit, well, the photography helps. If it's a molar crown and I want to get the shade right, yeah, of course I want that information. But as it gets more complicated, sometimes multiple units, two centrals, two congenitally missing laterals, a lot more complication comes in. Add in some implants, and we have an implant restoration, maybe a single or mixed in with other restorations. And it gets more and more complex as we go on, right? And then sometimes even in these complex cases, they're multidisciplinary, right? So I might have to use orthodontics or some surgical processes. And a lot of that's coming from the information in the photographic side to start with. So again, I think photography is just a simple way of how we're looking at this. And there's a lot more to it. So for me, I'd like to always start by thinking of what does it really do for me and what does it do for you, the people that are watching today. And I think the question I've asked over the years is, who are we? I know where most of us are dental technicians, some of us are dentists out there, but realistically, we're a team of people trying to create the proper environment for our patients. And I think that who we are kind of question is really about what we present to our patients. It's funny, I had a conversation with one of my doctors yesterday, and it's kind of the same conversation we've probably had over the years about what we believe and how we believe in something is really critical to how we approach how we sell the something. And I know sell isn't always the greatest word for us to use, but I think that that belief system of how we approach the cases is really your brand. And that brand that you create is really what makes you a viable process in the communication, whether it's to the patient or to the laboratory or to the doctor. That team unit is really about what makes you viable and how you look at things and how you treat things. So I think the branding component here is really important. And I want to be clear that for me, viability or being viable to the patients and the doctors and the technicians, because it works on both sides, right? I don't want to work with dentists that aren't valuable to me. I don't think they would want to work with me as a technician if I'm not valuable to them. It's really a team effort. So viability means that there's a mutual respect that we would have for everybody, and that the patients become more faithful to the brand that you represent. And what I mean by that is, it's funny, I live in New York, and I think it's kind of interesting that anytime I'm in New York City, you can't walk by one of these stores without seeing a line. Now, I know that seems foreign to some people, especially depending on the areas that you're in around the country or around the world for that matter, but it's kind of amazing to me that it could be a freezing cold day or a rainy wet day or a hot sunny day, and you walk past these stores, there's a line to get in the stores. And I always think that's interesting, and really, why is that? Why are those most expensive things people deeming to get a piece of or a part of? And the answer is because it's the brand. It's the brand that makes them viable, that makes them wanted. And by the way, it's not just fancy clothes or jewelry. I mean, you'll see the same line at one of my favorite bakeries in New York, like Ansel, Dominic Ansel. And Dominic Ansel is just a bakery, right, in the heart of Soho, a small little area. But you can't get in the store. There's a line down the block. Some of you around the country might know it from Cronuts, right? He got famous on the Cronuts, but he was famous way before that. And I think what's interesting is, look at the line of people that are waiting to get in there. Why? Because they want what he sells, and they don't care about the price. They care about the quality. They care about what he puts into that. And that brand is really important for us. And I'm not saying that being a different brand, I walked into Target, I've been into these stores, and I utilize them when I need to, but I'm not faithful to them. And I think that's what's important about this word about using photography in our practices, how important it is to me, because it's so much more important than just a simple, I take pictures, I get a shade, and that's how I communicate with my partners. It doesn't really work that way. I want to build faithfulness, and that faithfulness in our customers is really valuable to us, because not only does it build the practices that we work in, but it also builds a mutual respect about why they're paying for their services and the services we can offer. So in simple cases, yeah, basic photography is not a problem, right? We want to look at the prep shades. We want to understand that the preparations were done well, the color communication, then we could simply make, 2 restorations or any single restoration, depending on what the case is, right? Again, shade taking, prep shade, looking at the cuspid next to us, and then us fabricating a restoration. And I think those are all simple processes in the shade taking world. But it starts to get a little bit more complex when you're talking about more restorations, right? So when you're talking about 2 or 4 or even 6, 8, or 10, that process becomes even a little bit more demanding for us. At the same time, and I want to be cautious of how I say this, it's not only about the big, large cases, right? Because even in those small, simple, single unit cases that I'm showing you, and I've showed this single so many times before, it's still a process of how we get there, right? It's still a process of understanding the prep, understanding the space we have to work in, understanding the material that we need to make it work, and then the process of actually seeing it work, the evaluation of what's good and bad about it, and all the things that go into that. And by the way, without the photography after, how do I ever learn? How do I get better? How do I improve what I do? And how do I make choices that will make the next scenario better for me to use? So along the way, each of these processes, whether it's from the clinical side, the laboratory side, or just understanding the patient side, becomes really critical for me to understand each aspect of the communication process. And it's funny because when patients come in here, I had a patient walk in the office, was yesterday or the day before, and I walked in and I was like, oh, hi, how are you? And she looked at me like I was nuts. And I'm like, oh, you don't realize I've been looking at your picture and your photo for 5 weeks now. So I know you, or at least I think I know you. You've never seen me before, right? And already the communication process is starting for me. So I'm looking at it from a bigger perspective. So let's start with the simple parts, color. Now I get it that the basic photography is used to communicate color, and I would make the argument that when I'm looking at color, I'm always breaking teeth up into the basic 3 zones, which I think you all have a good reference of today, right? The cervical chroma, the middle third value, and that incisal translucency. I would also make the argument, though, that there is no such thing as a shade guide that represents natural teeth. There's references there, and those references can be chroma or value or translucency, but there really are no exact matches, right? And I think the joke you've probably heard me say over the years is D2 and D3 is a shade that people pick when they really have no clue of what shade we're really talking about. And that's because they don't always understand color. So let me explain it to you quickly from a different point of, or a different perspective. When we talk about color, we're talking about an entire world of color. And this whole globe that you see here on the left of your screen is all the colors that the color spectrum presents to us. And if we zoom in on that, that little area right here is only dental color. So this little area here is where you see what we call dental color. And what's interesting about that area is when you really look at shading, you're going to notice that the A and B shades fit in there fairly well for basic color. The B is actually outside, the B1 specifically. B2 and B3 kind of work in there, but the B1 is specifically outside of the shade. And then as I come down here, the C's and D's are nowhere close to the natural dentition shades. So if you've heard me lecture before, you've probably heard me say 1 billion times, C and D shades don't exist. And the B1 shade is the most remade shade in the world today. Part of the challenge with that is most of us are still using the classic shade guide. I'm not a fan of it. I'm kind of anti-classic shade guide, and I can go into a million reasons, but I won't do that today. I'm a big fan of the linear guides, the 3D system. And the reason I'm a fan of that is because I'm trying to make my restorations mimic nature. And when I'm looking at what nature is, I'm looking at the chroma on the cervical, the value in the middle third, and then that incisal translucency point. And as I'm building through a restoration, I'm thinking the same thing, chroma, value, and translucencies. And although no guide is a perfect representation, the 3D linear guide has a simplified system to help communicate what I'm seeing in chroma, value, and translucency. And that's why I kind of utilize that in my system. The other thing that I always say when I'm talking about shade is the one forgiving color for us for the retina, which is a muscle, is 18% gray. And this is the one color that relaxes the retina and allows us to see color a little bit more clear. So the longer we stare at a shade guide, the longer we stare at teeth, the less likely we are to see the coloration, because the retina as a muscle starts to fatigue 10 to 15 seconds, depending on if you're male or female. So for that, the shade guide has what we call an 18% gray band on it. And the purpose of that is you look at the shade guides next to the teeth, and then you drop your eyes down to the 18% gray to relax the retina. That was really the main purpose of having a gray base there for you to look at and to relax the eyes. The other advantage with the linear guide is it's not as confusing, right? This gets a little confusing when a doctor sees this for the first time, or even a patient for that matter. This is actually a much simpler system, and the way the system works is basically 2 steps. First step, what is the chroma? So I'm sorry, what is the basic value, not the chroma? Sorry about that. And the basic value is nothing more than are we in the 0, 1, 2, 3, 4, or 5 range. Once we know the basic value, then we're going to drop down and we're going to look for the basic chromas. And the chromas are going to mean that, okay, let's say we're taking a 2M2 and the patient's close to the 2M2. So now we move down to the 2s and we say, okay, they're in this range value-wise, but now are they more in the L or the R range? And to be clear, for most of you who don't know what L and R is, when you see a 2L or a 2R, 2L simply means that it's lighter or has more yellow influence to it. R means it's redder or has more, or I should say lower in value and has more red influence to it. So think of the 2M as being kind of the middle value, and then if we add more red or we add more yellow to it, you either increase value or lower value. So we're starting to utilize that concept, and it's a basic concept of what is the basic value of the tooth, and then how is my chroma situation? Is it heavier in chroma or more in the red, or is it lighter in chroma and more in the higher chroma values? And it's basically a simplified system of how to actually take a shade. I don't need this anymore. You'll see on my shade guide here in my office, I actually have an 18% gray card. I always had that on my old classic guide, but I don't really need it anymore. So I don't really use it because I basically have an 18% gray here. Also, I'm not calibrating my photos anymore. I used to do that years ago when I was really trying to understand color and get shades matched correctly. So the step is so simple. Step 1, what is the basic value? Step 2, what is the chromoscope that we're working in? And again, to be clear on the chromoscope, R means we're moving more towards the red, lower in value, higher in chroma. L means we're moving towards the yellow, higher in value, lower in chroma. So those are the kind of basic 2 steps and the basic 2 principles that we apply for all the shade taking processes. After that, if we're shooting with a polarized lens, which is what I'm showing you here, that polarized gives you a little bit more depth inside the tooth, and it's really valuable for me to utilize that. One of the mistakes I see in a lot of the clinicians today are 2 main ones. One, the dreaded ring flash. So using your flashes that are close to the lens is a no-no for shade taking. And the second one is photographing your patient while he or she is still in some sort of a dental chair. Whether they're sitting up or leaning back, it doesn't matter to me. I don't want them in a dental chair. I want them sitting or standing against a wall so they're braced and stable. And I want to make sure you're above the patient because I don't want the camera angle to be shooting up at the patient. I want that camera angle to be a little bit more horizontal to the flat of the lip or the flat of the tooth, or even better, maybe a little higher up where I'm getting a better angle into the angulation of the teeth, whatever that may be. That's my friend Sasha there from Harvest Dental in that photograph, by the way. I took that a lot of years ago when Sasha was here. So the other thing that you'll notice is when you don't have the patient sitting or standing in the right position, you kind of get what you're seeing here. This is a patient leaning back in a dental chair. The doctor is trying to get the angulation they want, and they put a shade tab there. Well, if I bring that patient here and I take the exact same photos with them sitting or standing against the wall, look what happens when I compare those 2 photos. The photo on your left is the patient in the dental chair, and look what you see when I'm looking at that tooth. Not only does it look short, but it looks like it has a weird value or warmth of chroma to it. And when I bring it over here to the patient sitting or standing, doesn't the tooth actually look longer, and the coloration of it actually looks different? So it's really important that that angulation of the photography is kind of worked in there. Third thing is your shade guides. And I've said this so many times, I feel like I'm repeating a broken record, but people still aren't doing it. I see clinicians still not doing it. The shade tab should be edge to edge to the incisal edge and in the same plane as the tooth, and then the camera should be shooting from up above or slightly above from the angulation of the tooth. I don't want shade tabs in edentulous areas. I don't want them on top of the teeth. I don't want them over the teeth. Those things really don't allow us to see the proper shading because the eye doesn't see color in depth as well as it sees it on a flatter plane. So it's really important that we keep those shade tabs in the right position. I also have a photo sequence that's really important. And for me, my photo sequence is basically, you've probably heard me say before, face, white, and pink. And that is the facial, the dental facial, and the dental, right? So I'm looking at the full face of the patient. I'm looking at the close-up to the patient. This shows me lips and teeth. And then I'm looking at retracted photographs, and those are with retractors and more focused on the pink and the white part of it, right? And those are kind of my standard photographs that I'm taking. And when I'm doing that, I've always explained that I want the patient either sitting or standing against the wall. And for those patients who move a lot, the trick I think we've taught many times over the years is put a little glove box or something behind their head so the head is a little bit more stable. And then it's easier for you to take a consistent row of photographs as you go through. These are my basic headshot photos. And you'll notice starting from the left to the right, I'll just run through them quick. full face smile, full face in what we call a Duchenne smile or an open mouth smile. Both of these are very similar. I'm sorry, I should kind of go back and start that again, just sort of I don't mess anybody up. Full face shot, full face open mouth shot, full face in Duchenne smile. And this is where the patient is giving the biggest smile they can and trying to show a little bit of pink if they can. A retracted photograph, left and right photographs. You could take both of them and those could be smiling or not smiling. And then lastly, what we call a midnight photograph. And the midnight photograph is basically this photograph. It's Duchenne smile, the biggest smile they can, with their head tilted down. And the main purpose of that photograph is just really to see the incisal edge position to the lower vermilion border. After the head photographs, we're going to move into the dental type or the white shots. And this is the repose photograph. So a patient is basically relaxed and we're looking at where their incisal edge display is. Big smile, so I can see where their teeth are and what the planes look like, and then left and right photographs. After that, everything becomes about the dental, and the dental is really about retracted photographs. So I could take open mouth or closed mouth, left and right, occlusal planes, and black backgrounds. And these, I think it's, I don't know, 15 photographs here, if I counted them all, are kind of the basic keys for me in every case that we work on. I don't touch a case until I have these photographs, and I'm not good enough to really evaluate my way through a case without seeing these basic photographic sections. And then after that, it becomes more detailed for the shade taking. Now, I do use tools. I'll be a homer here and say that I use the VITA Easy Shade. And I'll be honest in how I use that. I don't use it to just take my shade. I do all the shade work and shade evaluation first. So I'm looking at the patient, I'm using my shade guides, I'm taking the photographs, I'm coming up with an equation. Once I'm done, I then go to my VITA Easy Shade and I take 1 or 2 photographs of the patient's teeth. And I'm hoping that my information and the Easy Shade information are going to match. If they do, it makes me feel very confident that I did the right thing. And I could also use that, by the way, to photograph my restoration at the end and see if I got to the value in the chroma that I wanted to. So I'm really personally using it more as a self-check to myself. I think in the clinical environment, doctors should use it as both. They can use it as a determination factor of if they're seeing the shade right, but also to self-evaluate if they've taken the information correctly. I think both of them work better together rather than just one. I'm also using the OptiShade these days, and although I haven't perfected it yet, I'm feeling more and more comfortable with it as we go on, and it's pretty complicated. I'm not going to say it's completely, press a button and everything works, but it's basically a polarized little camera that I'm taking shades, utilizing those into the Matisse software, and then coming up with shade formulations for my VM9 or my VM13 or for whatever ceramic that I want to use. And I think in an ideal world for single essentials, it's pretty fabulous and it really gives me some useful information, although I still haven't perfected it. Okay, so managing shade is just one small aspect of it. And again, when I'm doing single centrals, I think it's really critical because I want to understand the prep shade, if it's a metal post, if it's an implant, and the adjacent teeth next to it and how I manage that. But those are just one aspect of cases. So single centrals, yes, really important that the photography is useful for us, that we see the environment, and that we make sure we make our restorations to fit into the environment properly. But it does get more complicated than just single centrals. They're not only, and by the way, I think we hear the word single central and we all think of number 8 or number 9, right? The 2-1 or the 1-1. It could be laterals, it could be lower teeth. It's just as complicated, right? So sometimes it's even more complicated when they're lower teeth and they're harder to match and you have less space to work in and they're really challenging to work through the processes. So again, this photography key is kind of the biggest key for me when it comes to not only the color, but then into the communication part. And as I say, the communication part, think about when we're working on something that seems fairly simple. We're going to replace a congenitally missing lateral. Okay, we're going to make maybe a Maryland bridge. Patient can't have an implant, or maybe they're not ready for an implant at this point. And everything seems like our normal process. We're going to take shades, we're going to evaluate the coloration and the material. But realistically, as you start to kind of work your way through a case, I'm utilizing not only the photography, but the common sense of the model work and what I have to figure out what's right for this patient. And right away, I hope you guys are looking at that case and you're thinking, that's a lot of space for a lateral. Maybe this should be an orthodontic treatment, and maybe we should be moving some of the teeth closer together, but boy, that's really involved, right? I'm gonna have to pull all the posterior teeth forward, close that space, and then that changes the occlusal concept, and right, it starts to snowball into a whole different world. So what we're gonna try to do is figure out what is the best scenario to manage our way through this case for this particular patient. And the way we felt was the right way to do that was to maybe treat the cuspid as a potential restoration. We don't have to touch the tooth. It could be an additive restoration. It could be additive composite or a window veneer, but we want to start to think about how to manage that space to the best of our ability. So we'll look at the space, we'll manage our way through it. We did treat this case kind of digitally. We did make a little resin printed bridge so we can evaluate the space to see what we could do. You'll notice in the bridge, and actually I give the doctor, I think Dr. Bernadette did this herself, actually kind of made the printed restoration herself to evaluate the space. So kind of prepared it for what we needed to do because she already saw the importance of what needed to be done there. And then I'm going to fabricate the final restoration. But now the challenge we have is when I deliver that final restoration back to her, she has to be prepared to either place a window veneer or make composite herself. Also, I'm going to modify the tissue. So we make these little tiny jigs here that guide the placement of this Maryland restoration. So again, the communication part here isn't just about the shade and the color. Now it becomes about the space and how do we help the clinical partner to seat the final restoration, because we know it's not going to be easy for them to seat, managing the fact that it's going to have no contact on the distal and that we're going to modify the tissue and there's only one wing holding it on, right? So again, a communication tool that becomes really important for us. That's not just about the camera. Okay. The other part of this is as I start to work my way through the cases, and I'm going to separate out the color now, and I'm going to think more about the actual teeth position. And I always say that the white supports the pink, right? So the tooth supports the gingival architecture, and then the pink supports the face, the lip support, and the dynamics of what we see in the face. And I think the key here is understanding that not everybody's lip dynamics are the same. Some people have a much higher lip dynamic, some people have a lower lip dynamic. So each of those lip dynamics will affect how we're going to treat the case. Whether it's a mesial-facial or a brachial-facial type patient, each of them have different ability to move their lips. So these are kind of our favorite, right? These are where, or I should say aren't our favorite. These are the ones that are the most challenging for us, where we actually have a patient where there's a very high lip dynamic and they're going to show a lot of pink. Also known as vertical maxillary excess. And these are going to be really challenging for us to restore because not only do we have to get the white to look good, we have to make sure that it blends in and harmonizes with the pink. Good news is only about 15% of the population are VME patients. The other 15% of the population are brachial-facial patients. And these are patients that don't really show any teeth. So no matter how much they smile, they really very seldom show a lot of tooth or a lot of pink. And I always say those are our favorite patients to work in. And then about 60% of the patients are the mesial-facial patients. And those are the ones that show a decent amount of teeth and have a normal lip dynamic that show basically 1 to 4 or 5 millimeters of tooth structure almost all the time. And that's the average of the patients that we're working in. So as I'm working on those patients, I'm thinking the same for every patient, whether they're brachial-facial or mesial-facial or dental-facial. I'm still thinking the same. My job as a ceramist or a technician is to manage my space, and managing the white part means I have to manage the pink part. The pink part means the emergence profile, phrase coined by my buddy Bernie Kroll years ago. I got to speak to Bernie recently. He's a retired dentist living in Florida now, but Bernie was the man who actually came up with the emergence profile concept. I think it was back in the 70s, if I'm not mistaken. And he has many articles about managing emergence profile, and he's working on a current one with managing it for implants today, which is actually a great topic. So I have to be able to understand that when a doctor prepares a tooth, that the tissue isn't always exactly where it needs to be, and my job is to manage some of that tissue. How do I manage it? Well, I need to have an understanding of what the tissue is. Is it a bio 1, bio 2, or bio 3 type tissue, meaning that is it very thin tissue, bio 1, or very thick tissue, bio 2? And it's important for me to understand that, because as I'm working my way through my cases, I need to understand that if the tissue is a very thin tissue and the patient has VME, high vertical maxillary excess, we're going to have a problem, especially if I'm dealing with implant world, or if the margin placement isn't ideal for me to manage that. So again, I'm not only seeing that in the photography, but then I'm going to utilize the photography to help me. What did I do here? I made a tissue cast. I took my camera and my flash and I moved the flash behind the tissue and I just took a photograph of it. So now I can actually see the light going through the tissue and I can really start to figure out how much tissue I have there. And that might change if I want to do a metal abutment or I want to maybe make a ceramic abutment to help manage the colorations of the tissues, right? So you see how all that kind of starts to play in together as I'm working my way through the restorative process. Now, also throughout our webinars, I've kind of gone through all the different types of restorations. I'm not going to do that today, except to say that no matter what restoration you're working on today, with the advent of implants and more heavier types of restorative options, pink restorations are up to about 25% in our market today. So even if you look at my desk right now, that means that 2 out of 10 pans, or almost 2.5 out of 10 pans, have some sort of a pink restorative that I need to do, whether it's a full arch of implants that I'm making pink on, or 2 or 3 units that I need to add pink on to. And that number has really increased. So that means we have to really be much more aware of managing our pink restorations as we go through. And I think you can see how many different types of pink restorations are getting done over and over in the labs today. So it becomes a lot more complicated as we go through that. And we've definitely addressed that in some of the pink face white and pink restorations or lectures that we've done that are probably still up on that YouTube site that Jim had mentioned to you before. So because of that, I kind of got into a different position where I start thinking about my cases, and I start thinking about them more as denture cases. Even though I'm doing more ceramics and I'm technically a crown and bridge person, we do dentures here in the laboratories and in our laboratory. But really, I don't know if I care so much about the denture process as much as I care about how we think about the case. And for me, I want to think about the case like I'm setting up a denture all the time. So even if a patient has teeth in their mouth, I'm pretending they're dentures, and I have the ability to move the teeth, lengthen them, shorten them, or figure out where I want them to be positioned. And if I look at it from that perspective, it really helps me think through, what do I need for that patient? Do I need orthodontics? Do I need surgical positioning for the gum? What do I really need to kind of figure out where the teeth belong in the patient's face? And to do that, we follow 4 simple steps. First step, what is the incisal edge position for that patient? Where does it belong in their face? IEP, as we like to call it. Step 2, it's once I understand the incisal edge position, I understand the horizontal plane for our patient. And if I understand not only the incisal edge position, but the horizontal plane, I think most of you watching this webinar already know that the average length of essential is about 10 millimeters, 9.5 to 10.5. And because of that, once I understand where the incisal edge position is, I now know where my gingival position belongs. So that's why step 2 becomes so critical for me. After I've done that to the maxillary arch, incisal edge position, and horizontal gingival plane reference, that's when I start to work on the functional capability. What is the functional capability? What's the vertical dimension that we're going to work in? And what is the lower incisal edge position? And we just went through this, by the way, in my last webinar, which was on the envelope of function. So if you didn't get to see that, go back and please watch that one, because I thought that was kind of an interesting topic and how we talked about it. And then step 4 will be bilaterally balancing. It's funny, right after I did that webinar, I got a call from an old friend, prosthodontist of mine, who's a fabulous clinician and a great friend, Dr. Lenny Colburn, and he said, you know, Peter, you kept mentioning bilateral balance, and bilateral balance is really a denture term. And I thought about it, you know, I think my immediate reaction was to be defensive and be like, well, it's not the way, you know. But the more I think about it, true, it's a term that we've used to talk about dentures over the years, but I don't think it doesn't fall into crown and bridge, because I'm looking to do the exact same thing. And maybe just the terminology might evolve over the years, but in truth, whenever I'm looking at balancing that horizontal plane, that occlusal plane, I should say, I'm looking to balance it to make sure that I have equal simultaneous contacts, whether it's in a denture or if crown and bridge, or if it's in a single molar, right? I'm looking for that same concept all the time. So if you didn't get to watch that webinar, please go back and watch the envelope of function webinar. That was, I think, was important. And I think the purpose that I spoke a lot about in that was really looking at every case like a denture. Now, one of the cases that I showed in that last webinar, I'm just going to run through it very quickly because this is where it also ties into photography. So if I'm looking at a case, I'm looking at my restorative space. Do I have to restore just the white, or I have to restore the white and the pink? And to do that, I have to understand that my average white is about 10 to 12 millimeters, and that is my average white restorative space. Sometimes I have more space than that, and if I have more space than that, right off the bat, I already start to realize that I'm going to be working in white and pink world, and I can see that right away in my photographic documentation, right? What's the patient's smile? What's the lip dynamic? How much space do I have to work in? And I think it becomes really critical for us to kind of think our way through it that way. So I won't spend a lot of time on this case. I just went through this case in the last webinar. But again, I want to be clear that I'm utilizing the photography the exact same way, right? So if it's an FP1, FP2, or FP3, and that's a term we use really more for denture world, but I'm still applying it to crown and bridge world, right? Why? Because what is my space going to be? Am I just restoring the white? Am I restoring the white and I have to worry about where the pink is? Or am I restoring the white and pink? So I want to kind of think through all of those aspects. And that's the difference between FP1, 2, and 3. And in most cases, I'm just restoring the white. But there are some cases, like the case I showed in that last webinar, that I thought was a really important one. So let me kind of briefly explain this, and then we'll finalize where we're going here. Whenever I'm looking at white, I'm also trying to determine how much pink is being displayed based on that lip dynamic. And I can see that in my photography. So right away, I'll know that if I'm restoring these teeth, and this is what the patient is showing, if they have a black triangle, if they have a square looking teeth or an oval teeth, I may need to think about the pink restorative. And that pink restorative could be surgical process by gum grafts or Botoxing the tissue, or it could be me having to restore some of the pink. So you see how the kind of concept of the photographic session, I hope you see, is kind of tying into where I need it to be. I also think, and I've showed this on many occasions, that the pink is not a straight line, right? So when I'm looking at pink, I'm looking at the teeth and I'm looking at whatever the ratio of that tooth is, that the pink is usually about 35 to 40% of the tooth. So if I'm restoring just the white, I want to support that 35, 40%. And if I'm restoring the white and pink, I want to think about the pink and where it belongs in the arch and how my white actually supports the shape and contour of the pink, either ceramic or tissue that I'm working in. So I don't want to spend too much time on the pink here in this webinar, but I just want to be clear that when I'm looking at pink, I want you to understand that the heights of the pupillas are going to be different from tooth to tooth, and sometimes even the angulations of them, right, kind of drop down as you see how much pink you're going to display between, let's say, central to lateral or lateral to cuspid, and that changes. I think that's really important for us as we're kind of evaluating the white and pink that we need for our cases. So this was the case that I had showed you in the last webinar, and I went through the exact same steps of where does the incisal edge belong, what is the horizontal plane, what's the occlusal OVD, and where do the teeth belong in our patient's face. And this is a denture case, and I won't spend too much time talking about it because, again, I just went through it in the last webinar. But same thing for me. This is where the photography now is actually going to help me. I'm looking at the patient's face, I'm treating it like a denture, and my question to myself is, where does the incisal edge belong? Step one. Where do I put the teeth in his face? Now, I don't know at this moment if this is going to be a denture, a fixed detachable, maybe a implant-driven hybrid, or maybe it's going to be crown and bridge. I don't really know that at this moment. And I have to be honest with you, at this moment, that's not my first concern. My first concern is, where do the teeth belong in his face? Once I've been able to kind of figure that out, then it becomes a lot easier for us to say, okay, I see where I want the incisal edge. I see where the horizontal plane belongs. And now I'm going to work through my occlusal vertical dimension, my envelope, like we talked about last webinar, and try to figure out where the teeth belong. I also have to think about the lip support. Will my restorations, be it full denture, partial denture, crown and bridge, implant related, will it be able to support the lip and the structure that I see there? So again, I'm using that information to kind of work my way through the entire process of what I'm going to do. And I won't spend too much time on this. I keep saying that, I'm sorry. I felt like I just walked through this case twice in the last month. But I think you already understand the concept that if I understand where the tooth belongs and how it fits in the face, then whatever the restorative becomes a little bit easier for me to help manage the space. So in this case, we wound up removing most of the teeth. 4 implants were placed on the upper. I think there were 5 or 6 placed on the lower. Maybe there were only 4 on the lower, I don't remember. But anyway, the point of it is once I understand where the teeth belong, now it becomes my understanding of what are we working in, FP1, FP2, or FP3? Do I need pink to support his lip, or will the white give me everything I need? And if the white gives me everything I need, does it give me enough that I have papillas where they belong, or am I making him very long teeth, right? I have to kind of make that evaluation, and that evaluation is going to be about his final lip dynamic. So in the end, we realized that we felt, and I'll go back one, we felt that if you look at the upper lip here, you can see that there's a little bit of a negative space, that he really needed some pink support. And to do that, we're going to bring this case into denture world. So this is going to become a denture type case. We're going to design a bar. And again, I've walked all the way through this before, so I don't have to go through it again. We're going to make him final dentures. And yes, it was 4 on 4 on both upper and lower arches. We'll place the implants. Now, this could have been a crown and bridge case, and I would have treated it very much the exact same way. We chose to go with a Toronto restoration for this. And I don't mind working with denture teeth. I actually like them. I think I've pointed out in other webinars that a lot of the VITA denture teeth today are really aesthetically pleasing, and they have the right fluorescence and colorations in them. So that kind of makes it better for us when we're working through the cases. And if I don't like the teeth exactly as they are, I'm free to modify them, just like in crown and bridge world. I could sandblast the teeth. I can use some of the accent stains and add a little bit more chroma or some check lines, or increase the mamelons or increase the translucencies. So I really have some nice abilities of things to do in denture world that is still, to me, very aesthetic, and I think really important for us to make these look proper as we're working our way through. So in the end, you can see that the lip had the right support, and we really worked our way through the case by doing all the things that we said. Where the teeth belong in the face, what was the lip dynamic that we needed, and did he show some pink, and how much, if he did, how did we manage that in the final restoration? So I think in the end, for me, that's kind of the really important part of managing that. But I don't want the implants to twist us into a different world of how we communicate the aesthetics, right? So I always say, even if we're doing implant restorative, treat it like you're doing veneers, because for some reason when we do veneers, everybody acts like the photography is the most important, and the coloration and all the little details seem to be more of a focus to us. I think that focus should coexist in any other restorative option that we're doing. So let's pretend that even the implant is going to be a veneer. And now if we're going to treat every case the same, photography-wise, then it's just a matter of us filling in the restorative aspect as we go through the process. So for a patient like this, yes, it will be an implant, but it's a highly aesthetic-driven case for us. The patient presents with a challenge that they're very unhappy with, that one cuspid, they like the rest of their teeth, one lateral, I'm sorry. They like the rest of the teeth. The patient's wearing a flipper, but they're tired of wearing a flipper, and we have to manage the aesthetic. So I'm going to ask my doctors to treat it just like it's a veneer case, the same shade work, the same using the shade position, shade guide in the proper position. And again, this is a mistake, right? I don't want the shade guide in the edentulous area. So that's a no-no for us. I want the shade taken just like we're managing for a high-end aesthetic case, not for just, we have to put an implant in the restoration. We're going to treat it exactly the same. Implant will get placed. We're going to prepare our end by making a little implant jig for the doctor to insert the abutment. We're also going to make a little cement jig for the doctor, and this is so that when they're cementing the case, if it has to be cemented, they can use that little cement plunger to get the excess cement out, because we don't want to have excess cement during the placement of the final restoration. And then we're also going to make sure that our margin placement was correct, right? Now, if I go all the way back, I don't want to go too far back here. Let me go back here. Look at the patient's big smile. Do you notice that when she's really, really laughing, this would be a Duchenne smile, that she shows an awful lot of pink there. But yet, when we ask her to smile normally, she has a little bit more of a controlled smile, and you don't really see the pink. So this is why that photographic importance for us is so important, that we capture all the information we need to understand if the patient really is showing pink or not. I would make the argument, treat it like they are anyway, because our job is to manage the white and the pink. But I want to make sure that I don't bury my margin too far so gingerly. So I'm going to try to go as close as I can to the pink. Interestingly, on this case, after I made the restoration and I sent it back to the doctor for a color try-in, apparently the patient's tissue actually shrunk up a little bit more. And now it became a problem for us, because on the cast, my margin was about 0.3, 0.4 tenths of a millimeter buried, but in the mouth, my margin is now exposed, which means I had to rechange the abutment, and I had to actually drop the facial margin of the final restoration. So no big deal, but we wanted to make sure that we did that, because we knew that in a big laugh and their most high lip dynamic, the patient would show that marginal integrity. So we had to go back and make that adjustment. I went back and adjusted the abutment, added to the crown, made a new cement jig, and kind of made a new abutment, so we could, not a new abutment, a new abutment jig, so I could make sure that I was kind of managing that space as best as possible. This way, in the big laugh, when the patient smiles, they're not showing anything that didn't really blend and harmonize with the rest of the restoration. Could she get more tissue there? Yeah, a different challenge, maybe a little Restylane filler or Botox filler sometimes helps in that, or a tissue graft. The other thing I wanted to be clear about is that if I'm looking at every case like a veneer case, and I don't want to run out of time here, then as I'm taking my shades, and I'm going to kind of go backwards on this, I want you to think about taking your shades a little bit differently. When you take your shades, most of us taking our shades to understand the value in the chroma. When I'm taking at shades, I'm really looking at the shades from the restorative transition point of enamel. And what I mean by that is, what is the enamel that I need on the case? Is the enamel that I'm looking at a very milky or white enamel? Is the enamel a very translucent enamel? Or is the enamel a very transparent enamel? And from the clinical side, for the doctors that are out there, this is a really important part for you in the communication, because you're not picking your shade just on that basic value. It looks like a 1M1, it looks like a B1. That's one part of it. The second part of it is, what is the translucency your laboratory partner needs to use? Because if they need a high end or a high amount of translucency, not a high end, a high amount of translucency, that means the shade reference is going to change. I think we're all aware that once we put translucency on a restoration, it lowers the value. So the more translucency I need, or the more transparent the tooth, the more I have to be concerned about what the value is that I'm actually taking. So for me, when I'm taking a shade, my first evaluation is not the value, it is what is the translucency of the tooth that I'm working on. And then I'm going to start to look at the value. And if this value looks like a 1M1 or a 1M2, I should know right away that in order for the technician to fabricate this restoration, that they're not going to be using a 1M1 or a 1M2 restoration, or dentin, I should say. They're going to have to use something much brighter, because in order for me to get the value to appear like a 1M1 and cover it with that much translucency, the ceramist is going to have to think differently. They're going to have to think differently about how that light filters over the final tooth and the final restoration. I believe we also covered that in one of the previous webinars. I don't remember the title of that webinar, but I'm sure Jim might remember it. He could tell us at the end. So I'm utilizing my enamels to kind of cover that. The best example for that for me is from my friend Adam Maleshko. Adam's a fabulous technician here in New York, and I think Adam and I will be speaking at the same event. That'll be the SCAD ProSec event. I think that's in October or November in Chicago this year. So if you guys have a chance to attend that event, it'll be a great event with a lot of great speakers there. But I took this demonstration really from Adam. He utilized it from his book, so I don't want to take credit for it. And the point of it was, he talks about it, and I always talk about enamel as a filtration system, because that's what enamel is. So the more translucent it is, the lower the value is, the more you start to become in the gray world. And the whiter the enamel is, the more that it filters out, and then that doesn't allow you to see into the tooth. So here's the best example. Look at your colored pencils, and you'll notice that as I color those with transparency, and the transparency is 0.2 of a millimeter, 0.4, 0.6, and 0.8, you should notice right away that I'm losing the ability to see some of the color, but I'm also losing value and becoming grayer and grayer as I go down the scale of color. If I switch that to a whiter type of enamel, or something with more white and brightness in it, well, the same thing starts to happen. I start to mask out the coloration I see underneath, and the thicker the enamel becomes, the less I see of what's behind it. And it gets to a point where I almost don't see any color, and I just see the white enamel. So I have to really be thinking of my translucencies and my restorations before I really start that final restorations. And to put this all together, I'll finish this with this one case because we're just about on time here. When I look at the face, I'm taking everything into account in the photography. I want to look at the face. I want to look at the white and the pink. Where do the teeth belong? And I want to really work my way through the case for our patients. This happens to be a young patient, Nina, that I just finished up. I think I finished her about a year or two ago, and I just got her back finally for some final restorations. And Nina's a long, involved case that I won't go through all the details with today just for time, but I'll give you the basics. I'm looking at her face. I'm looking at where the teeth belong. And once I understand where the teeth belong, now it's our job to start fulfilling the restorative process. And in this case, it was a complicated restorative process, right? A lot of implants. I think you can see here that I wrote on the screen that Nina was born with alodontia, which is, I think the classification of that is missing more than 6 teeth, if I'm not mistaken. And if you look at it from that perspective, there were implants placed when she was fairly young, I think over 18. Somebody had done some restorative on the 2 centrals, but I didn't want to really be limited by those. So I kind of wanted to really think through the case like a denture. Where do we want those teeth to be? And I've asked the doctor if he would mind removing those restorations, and he was all for that. And if I'm not mistaken, I don't think we even charged the patients for one of them because they were done not that long before. And we felt that we wanted those restorations as part of the final case. So I wound up working my way through the final case. We haven't finished her lower yet, by the way. I think we're still working on some aspects of the lower, but in the end, this was a final treatment plan for her. But what's interesting about this case is once we worked our way through, you're going to notice there was a lot of different types of restorations here. I have a veneer. I have a metal ceramic PFM next to it. I have 2 implants with set screws on the lingual, full coverage, another veneer, right? So a lot of different types of restorations. And like I said, the restorative options really were only critical after I understood where those restorative options worked, where the teeth belonged in that patient's face. And again, that to me is always the most important part of that photographic communication. So Nina finished up as a happy camper. This was a case with Dr. David Castellano in New Jersey, a heck of a clinician and a great guy. And I think it was really a fun case to kind of work through. And Nina was really happy. And those are the things that matters at the end, right? Is seeing the patient and watching them talk and speak and all the things that kind of go through that. So
I look in the mirror every day and I smile just thinking about how amazing this whole thing has been now that I'm done. But
we work with a great doctor. All right, so I'll leave it there because I think we're just about out of time, and I want to leave some time for questions. But I want to be clear and say that the success of that case, of the success of any of the cases, isn't just about using a camera for shade, right? It's about looking at every aspect of how we're looking at the patient, how we're communicating back and forth. And by the way, that communication process builds a belief system between myself, the teammates that I work with, and the patients to understand the value of everything we do. And I believe that's how we build the best brand to support what we do for the entire dental profession. So with that said, Jim, I think I'm just about on time. As usual, I squeezed in too much, but I'll say thank you, and hopefully we have a few people with a few questions. Thank you all for joining in for another webinar.
Yeah, fantastic, Peter. I think you said it right that photography is beyond shade. It's more of a diagnostic treatment plan tool that really is essential. CE, those of you who've been asking about CE again, we will send you the CE letter information if you're a NBC or a Florida technician. We're going to go ahead and submit those to those respective companies for CE. The workshop was recorded, the webinar was recorded. It'll be posted here in a couple of days. Please visit us. Even Peter had mentioned that, you know, there are so many different topics that we've been doing with Peter that each one kind of maybe builds on each other. You can't have one webinar that does everything. So we've got hours and hours of Peter online that you can go visit our VITA North America website and watch and pick up more and more pearls of wisdom from Peter. If you need to get a hold of the whether you're Canada or US, one of your reps, you can get a hold of them. This is the list. We also have the help desk, myself and Paul, and then of course the VITA North America YouTube channel as well. This is the information for the help desk. We do have some additional programs going on, so we do have, you know, come visit us. We have remote workshops, we have denture courses, we have crown and bridge courses, ceramic courses. Peter was showing it earlier, but there is some information, contact information that please, you know, join us and get a hold of us or get a hold of Peter using that contact information. Peter is a working commercial lab, very busy, travels a lot. So if you email him, just give him a ping, let him know that you want to talk to him. He can arrange to do that. Just a couple of questions now, Peter. One of the questions is if I can't be at the office to take the image, what are the you know 2 or 3 essential pictures? Is it just that facial dental imagery? Is that enough, or are there others that you think they must have?
Yeah, so I think the shade sheet that I had put up there with the facial shots, the dental facial, and the dental shots are kind of the key. If you don't have those, if you didn't get a picture of them on the screen, you can kind of email me and I'll gladly send you that my protocol. Other groups have different protocols, AAED, AACD, but they're all very similar, to be honest with you. And I think it's really important that those are the basic shots for basic communication. If you can't be there, then I would argue that it's your job to teach your clinical partners how to take those photographs and teach their assistants. I could tell you last week, I think it was maybe 2 weeks ago, I had one of my offices drove 2 hours with their whole 13-person staff, and they spent 2 or 3 hours here going through photography and getting the staff up on board, right? So I think that's a real important part of teaching. And then the other side, also it gives you value, right? So as a technician, it gives you value for the doctors and the clinicians to understand what you do for them. And then the second part of that is those basic photographs are just basic diagnostic tools. If I need more shade taking, polarized photographs, then it's a little bit more involved.
All right, and then a two-parter. What's the best camera to use? We always get that. And then also, will just a smart camera, a smartphone work? If that's all the doctor has.
So no, no, and no for the smartphones. I had slides in there that I had jokes about the phones and picture taking for Instagram and all the silliness that goes on. I'm sorry, an iPhone is not a dental camera. Can it be helpful to show a face and a tooth position and facial feature? Yes, it can. But once I'm getting into detail, coloration, the things that I want, you need a good quality camera. I'm kind of still in the old school camera world of I'm using a Nikon D750 with the right lenses and lighting and so forth. I would venture to say that for younger people, our future is going to be in the mirrorless cameras. And I'm actually going to buy a Sony, I think, probably in the next week or two. And the only reason I've hesitated on the mirrorless type cameras, just to be clear, is they're very expensive right now, and they don't have all the components we need, lenses and flashes, for dentistry. But they're getting there. And I think in the next year or two, you're going to see that those are going to be the kind of cameras that replace. But without giving you too long-winded of an answer, here's the good news. You can get into old school SLR cameras, which is what I shot every photograph you saw in, and you could probably invest about $2,500 and be set for the rest of your life. And it has everything you need. If you want to go into the next phase, which is going to be the mirrorless and the higher end new cameras, you're going to have to spend about $8,000 or $10,000 right now, and it's evolving, right? So it's going to be a lot more of an investment and a lot more changes as it goes on over a period of time. So depending on where you are, I'm kind of pushing people to stick to the old school. I just bought a whole setup for one of my doctors recently. I think he spent about $26,000, maybe $3,000, and he's good for the rest of his life. So he won't have to dive into the other ones.
And you actually touched on one of the questions, which was any testing of a mirrorless camera, whether it's better or not, but you kind of just addressed that. So thank you very much.
They're better, and they're going to be fabulous. They just don't have all the components we need yet, but they're getting there.
Great. That'll be, I look forward to seeing those. Do you alter your shade tabs at all to better fit the two? Some people like make a step or onto the actual shade tab so they can rest it right on the incisal edge of the tooth. But do you adjust any of your shade tabs, physically adjust them?
Oh, do I physically adjust the shade tab? No, I don't. I'm too lazy to do that. I just put the incisal edge to incisal edge. Sometimes I'll put cervical to cervical, but in truth, look, the shade tab is a shade value reference. That's really its main job, right? So I'm not looking at it as the end all, and I've always made the argument. I think I've said in clinical lectures where I've had a large group of clinicians in the audience where I say, if you could find one tooth that matches any shade guide perfectly, I will do your restorative work for free for the rest of your life, because it does not exist. There is no such thing as a shade guide that matches a tooth. There are just references for us: value, translucencies, chromis.
And is there any difference between a photo taken in black and white versus a color photo that you turn to black and white? I mean, do you do both, either?
I don't take any in black and white. If I want a black and white, I'll convert it. And the really only purpose for black and white is just to show value. But I'm kind of getting that value with my shade system. So I don't really switch to black and white really anymore. I don't think there's any scientific difference between the two, but maybe there is that I'm unaware of.
The Maryland Bridge case that you had, what material was that made of?
It was the Maryland Bridge case was Bernadette's case. It was a one-wing zirconia bridge. I'm not a huge fan of zirconia for Maryland bridges, to be honest with you. I've done more probably in the last year or so than I'd like to. We are doing them, but it's not my favorite material for that. I still think a metal ceramic for Maryland bridges, especially with one wing, which is the way we do all the Maryland bridges today, is really the better option.
All right. And then the zirconia cases, whether implants or not, that you have to replicate the gingiva, the soft tissue, pink tissue. Do you pre-color your zirconia before you sinter it, or do you do all the pink color post-sintering in porcelain and so forth?
Yeah, so I think if I'm understanding the question right, on the bigger bridges like the Zurich bridge, if I'm doing white and pink, you can add in pink in the pre-sinter stage to do it. I have to be honest, there's two flaws with it for me. One is if you actually flap tissue away, the bone is kind of white. It's kind of a B1-ish, A1-ish color. So realistically, when I'm building pink, I want to build it on white, not on a depth of pink. That's problem one. Problem two is I don't like any of the pinks from any of the companies that are the internal use for these non-sintered zirconias there. They kind of look like violet. They're really not pretty colors. So have I ever done them? Yes. I'm not a huge fan of them. I kind of believe that I want to cut the pink back enough that I could put a little bit of a pinkish stain if I want to, and then usually layer some small amounts of pink ceramic on them. I feel like that's where you get the best result.
All right, Peter, thank you again. I'm sure that the audience learned a lot, like we always do with your webinars. Any last minute comment you want to make to the group?
No, I'm cramming, so I got a case full of desk full of cases out there, and I'm leaving on Friday for Europe, and it's been one of those. Matter of fact, I didn't know we had this webinar until about 11 o'clock last night, Jim. I saw your email, and I'm like, oh, damn. So I was cramming because it's been a crazy week or two, and I kind of missed it on my calendar. But no, thank you guys for tuning in. I look forward to seeing you soon again, whatever the next topic may be. And I hope I didn't rush through it too fast, as my usual nature is.
No, not at all. Thank you for your time. Appreciate it. We'll let you get back to work. Thank you, everyone that joined us today. Join us again for another VITA Academy webinar in the future. Just go to the VITA North America website. You can find some additional webinars that we have scheduled. So this will conclude today's webinar. Thank you.
Thanks, Jim. Take care, everybody.